Hello, my name is Nurse Practitioner Ray, and we're here today to discuss the case of Mr. Billy Noble. Date of birth February 21, 1981. Chip complaint, male patient. Chip complains, my face just dropped. This is a 40-year-old African American male who comes to the ED with a history of hypertension and and a smoker for 20 years, one pack a day, complaint of acute onset, right-sided facial droop, and right hemiparesis. Symptoms started at 2 p.m. While at work and resolved within 15 minutes upon hospital transferred by EMS. No contact with similar symptoms, denies previous episodes of similar occurrence, no active aggravating or relieving factors noted, denies intervention and any medications taken, denies pain, claims 0 out of 10 on a pain scale. Non-drug allergies, is taking amlodipine 5 milligrams for his hypertension. All immunizations up to date. No significant past medical history and surgical history apart from mentioned. Lives with 2 children and the wife. Graduate school degree. Feels safe at home. Lives in a gated community and it's a bungalow. Drinks 1 to 2 bottles of wine and 1 to 2 beers, bottles of beer in a week, a few times a week. No history of drug use, and of course is a smoker as mentioned. Mother has diabetes, dad has hypertension, no siblings. Review of the system is unremarkable. Emphasis on neuro, facial droop, and right hemiparesis resolved. Psych with no emotional changes, memory problems, or depression or suicide attempts. Vital signs are within normal limits. A remarkable head-to-toe physical assessment. Neurological-wise, no acute distress, sitting comfortably in bed, well-groomed. He seems in good health, good condition, good hygiene, no waters noted, with good attitude and very much awake and alert. Answer questions appropriately and maintain good eye contact. Psych, no memory loss, foggy thinking, emotional changes, no sleeping issues, indication of no indications of depression, expressing mild anxiety about current condition. Review of laboratory and diagnostics, cholesterol's borderline high, LDL is borderline high, hemoglobin A1C is high. Carotid ultrasound demonstrates stenosis 45% of the left internal carotid artery. Other tests are within normal. Differential diagnosis is a focal seizure, migraine, hypoglycemia. Final and medical diagnosis is TIA, transient ischemic attack. Plan. Neurologically, of course, no active issues at this moment, but we'll consult to neurology, neurosurgery for possible revascularization. Repeat carotid ultrasound, CT, MRI, MRA, and follow up with a PCP within 3 to 6 months to a year, or if it got worse. And then probably very anxious, so can refer to social service, case management, or possible site consult. Education for stroke, smoking cessation, and lifestyle changes. History of hypertension, increasing the amlodipine 10 milligram once a day for BP management to keep and maintain blood pressure below 140/90. Start atorvastatin 20 milligram for newly diagnosed high lipids. Loading dose of aspirin 160 milligram one time, and then maintenance at once a day. 12-lead EKG, of course, lab, CBC, CMP, PT, PTTI, and RMAG-FOS to identify blood disorder, diseases, clotting issues, inflammation, infection, and immune system problems. EKG for the AFib. Refer to cardiology, follow up 3 to 6 months along with the lipid panel TE, and then with the PCP 3 to 6 months to a year, or if it got worse. Endocrine, newly diagnosed diabetes, consider lowering A1C below 6, blood sugar checks and control, keep normal BMI, metformin diet modification, consult endocrine doctor and nurse of proper diabetes management, follow up with a PCP 3 to 6 months to a year, or with any concerns. Respiratory, GU, GI, HIM, ID, with no active issues. Thank you very much. That's my presentation.